based on you set the machine with these targets that I've mentioned in the initial ventilatory settings. So that is clear. Uh, Next slide, please. Next. So the next slide was just on complications of mechanical ventilations, and you can group the complications based on is it or due to the equipment used. The equipment can malfunction or it can be disconnected, or again you can have incorrect settings or incorrect mode. And the other complication is pulmonary. During intubation, you can cause damage to the teeth, vocal cords of the trachea. Then there's also a risk of ventilator-associated pneumonia due to reduced lung defenses. There can be also barotrauma. So there can be barotrauma or volume trauma due to pressure or due to the volume, the tidal volume that you've set. You can also have oxygen toxicity or a patient ventilator asynchrony if you did not set the correct setting. Probably your patient required just pressure support, but you're giving also volume support. So there can be a patient ventilator asynchrony. Then complications associated with circulation. Use of ventilator causes reduced ventricular preload. That's as a result cause reduced cardiac output. There's also increased right ventricular afterload. That is if the lung is overdistended. There's decreased planchnic blood flow with high levels. When you set the PEEP to be high, there can be reduced level of planchnic blood flow. Then there's also risk of increased intracranial pressure with high level of PEEP. Then there can also be a risk of fluid retention due to reduced cardiac output. Then the other complication would be like gut distension due to air swallowing and hypomotility. You can have mucosal ulceration. You can have weakness of peripheral and respiratory muscle due to disuse. There's also a risk of sleep disturbance, agitation, and fear, which is uncomfortable to the patient. Then also the neuropsychiatric complications. Next slide, please. So now once you've done the mechanical ventilations of your patient, what criteria should you use to know that it's time to wean off? So usually wean off your patient if there's evidence of the reversal of the underlying cause of respiratory failure. So when you check the partial pressure, the patient is able to maintain their own partial pressure of oxygen. They're able to maintain their own PEEP. They're able to maintain their own FiO2. The pH is now normal. Then the patient is hemodynamically stable. Then also the patient is able to initiate the respiratory effort by themselves. The critical breathing trial. So when you try to wean off your patients, when sorry, can't see the slide. So when you try to wean off your patients, basically share the slide. when you try weaning off your patient and then you notice that the SpO2 is still less than 90, it shows that there is a failure of achieving spontaneous breathing trial. If the respiratory rate is still above 35 breaths per minute, again, it shows a failure of the patient to achieve spontaneous breathing trial after weaning off. If the pH is less than 7.30, still again shows we are having respiratory acidosis and still indicates failure of spontaneous breathing trial. If the patient is still in respiratory distress or the patient has two or more of the following, if the patient has tachycardia, if on your examination you notice there is marked use of accessory muscles of respiration, or there is diaphoresis, the patient is sweating a lot, there's marked subjective dyspnea. If on your examination you notice your patient is dyspneic, or there's abdominal paradox, that is when you define that spontaneous breathing trial in this patient has not been achieved, and you might consider going back to introduction to mechanical ventilation. The how different modes are used will be discussed when you're covering mechanical ventilation in ARDS and the other topics. Any question?
Thanks, Faith. I think there being no other question, I think we can proceed to Dr. Wanjiro's presentation. I'll just project for her. Sorry, Faith. Dr. Kapanga has a question for you, if you wouldn't mind unmuting and just answer it. She asks, is there a step-by-step general plan for weaning off a patient from the vent? Also, how to downgrade until the patient is off mechanical ventilation? Are you able to answer? Can you hear me? Okay, maybe just to touch on it.
Okay, I'm not quite so sure, but if there's a stepwise approach, but from what I've seen, we've always gone downgraded based on the patient's response. And it's also dependent on the patient's underlying condition. So if the, usually we assess, have we been able to reverse the underlying condition? If the patient was hypoxemic, are we now able to get adequate oxygenation? Then, if the patient was sedated, for example, in anesthesia, are we now getting off the sedation? So we have what I've noticed, we always taper down the values based on how much the patient can give back. But the senior doctors can respond on that. Thank you.
Okay. So one thing also that I've seen, if I may chime in, is that in as much as the underlying condition is also being treated and we are coming off it, um, there's there's always an attempt to try and reduce the ventilator the ventilation dependency. So by attempting to reduce the FiO2, maybe on a day by day basis or maybe 12-hour basis.
And then in addition, I also know that the pressure support, the PSV mechanism, the pressure support ventilation, is the mode that is commonly used when we are weaning off the patient. But anyone else can comment on that. Thank you.
Yeah, I think she's right. We can proceed. Dr. Wanjiru, are you on the call? Dr. Wanjiru Ngugi?
I think she had said she'll be running late. I don't know if she's already in. So I don't know if we can move to your presentation as we wait for her.
So, no problem. Uh,
Hello.
all right.
Welcome to the free carnival. Okay. Yeah.
So, just give me 1 second.
Hi, I wanted to add, I think we're going to be doing a topic called weaning of mechanical ventilation and extubation.
Okay.
So I think we'll cover it more in detail there.
So, all right. Okay. Can you guys hear me?
Yes.
Okay. So just to proceed. Um, let's see. Okay. So we'll do mechanical ventilation and obstructive disease. This is another short presentation. A lot of the bulk of and the nitty-gritties and the details of mechanical ventilation should be what has been covered by Dr. Faith and Dr. Margaret as well, Dr. Anchiru when she steps in. Nonetheless, specifically for obstructive diseases, this is when we're dealing with chronic obstructive pulmonary disease most commonly, and asthma. These are the two most common. There's also bronchiectasis, although we need to have an asterisk on that because it's sort of yes and no obstructive, mostly because of the secretions and the mucus that's hindering rather than the airways narrowing. Yeah. And funny enough, the airways actually widen and thicken rather than narrowing. But the specific management of that would be a bit different, as though they could still be put on mechanical ventilation when they meet the criteria for intubation, or for intubation mostly. So by definition, these are conditions that cause airway narrowing, leading to difficulty in exhalation, like I've mentioned. Now, if we can start, we can check for asthma. So generally, the diagnosis of asthma would come about because you've had that wheeze or a cough and shortness of breath and chest tightness. We all know the diagnostic criteria for that, as well as checking your FEV1 to FVC ratio. And then we need to consider your signs of asthma exacerbation. So your tachypnea, tachycardias of 30 and 120 respectively. The use of accessory muscles of breathing. These in particular, just to run through them, are your sternocleidomastoid, your pectoralis minor, your scalene muscles, your external intercostals, and your rectus abdominis. Sometimes diaphoresis as well, orthopnea, and inability to speak in full sentences or phrases. And then your pulsus paradoxus. Another asterisk on this situation, because in especially in asthma, if you're getting air buildup, like high intrathoracic pressure, you get a reduction in your preload and consequently your cardiac output, and it just becomes worse. So your peak flow measurement is the most diagnostic feature, and patients with impending respiratory arrest must be the ones who you would heavily consider intubating. Yeah. So when they're starting to get to slow respiratory rates they're starting to get fatigue. This is after they've been getting tachypneas for quite some time. They have a reduced mental status, just as you're assessing them. They have an inability to maintain respiratory effort, so shallow breath sometimes also, worsening hypercapnia and acidosis if you're able to do BGA, and then inability to maintain saturations above 92. Now, acute exacerbation then is what would chiefly help us indicate for us this patient is probably the one who needs mechanical ventilation, which of course, as from previous discussions, involves the non-invasive ventilation as well as the invasive ventilation. Now, from what studies say, it's NIV is being tried more and more, but its role has not been studied very well. Yeah, in comparison to COPD, where you have your NIV having more beneficial effects. However, in patients, of course, who are uncooperative on that NIV, then you have to sedate and intubate. But you have to consider also the kind of medications that you're giving, because these ones may also worsen the condition. So it give you a bronchodilatory effect. So especially ketamine, IV, halothane, isoflurane, and sevoflurane. Though the anesthetist would best advise on this. But they're not too many randomized control trials for and some adverse effects have been shown for these medications. For COPD, sorry for the busy slide, but I just wanted to highlight, let's look at the right half first of all. So patients who have exacerbation, so you're getting your arsenic dyspnea or cough and sputum, patients who are accompanying, this is a patients who have accompanying tachypnea and tachycardia. So you of course try your NIV first in acute exacerbation, especially even the patients who, if you just mentioned the COPD and obstructive sleep apnea overlap, the patients who have the two. Mostly because of the demographic, the two can overlap. an NIV would be appropriate in this situation because you're basically killing two birds with one stone. So, and people who are recovering from life-threatening exacerbation, so you're trying to then now wean them off the bent from intubation to put them on NIV. As per our NIV discussion last week, there's some of these indications are mentioned. But all in all, you need to intubate when signs of respiratory failure some come up. Yeah. Now on this left side, it's quite busy, but the biggest part is this section over here. Sorry, the biggest part I wanted to highlight is this section. Just a moment. Is just this section of severe here. So these are the patients that you'd when they come and you're doing your initials and you're doing your assessments, these are the patients who you should technically have a low threshold for intubation. People who have a bit of a mild or a moderate exacerbation, then you could try and consider the NIV first as you try and assess the situation. But the ones who you need to have a low threshold are these ones who have severe exacerbation. Yeah, especially in COPD. Now, so what happens is in obstructive airway diseases, you're having your decreased airway, your increased airway resistance because you're getting a narrowed airway. Yeah, it's a bit dramatic, but just to show us how it happens. And then you're getting your airway trapping, so you're getting your hyperinflation because you're not ventilating as well, and you're getting increased work of breathing as well. So it's a whole mess. You're trying to breathe more, trying to ventilate, they're not able to ventilate very well. This is with the background of the fact that inspiration is the active process, expiration is a passive process. So as you're trying to inspiration, you can always control it and make it more profound or faster, but expiration sort of you have little control of it. Yeah, and we'll see how this translates in the vent, right? So generally, when you put them on a vent, you're trying to prolong the expiratory phase to prevent the dynamic hyperinflation. So you're trying to avoid this situation right here. And we shall look at that as we go. Your goals of mechanical ventilation is to reduce your work of breathing, your adequate oxygenation and ventilation, to minimize your air trapping and auto PEEP or intrinsic PEEP. So this is when, like Dr. Faith has mentioned, PEEP, that positive end expiratory pressure. The pressure that's left there at the end of your exhalation.
Oh yeah, exhalation.
Because you're getting narrowed airways, because you're getting a narrow airway, you're getting poorer ventilation, and the passive process of expiration does not necessarily account for the narrowed airway, because you're not able to ventilate and get oxygen and to get CO2 out as easy. So it kind of takes its time. So what happens is that you have a higher and higher buildup of the air that's left within. Yeah. So that's what we call auto PEEP. We're going to see it in a diagram, but the pressure of the air that's left within keeps increasing with every breath. That's what we call that intrinsic PEEP. So you need to also avoid ventilator-induced lung injury and the other likes. Also pneumonias and the like, the other complications of intubation, right? Now, one thing to mention before we proceed is the fact that intubation needs to be done with caution, especially in asthma, mostly because manipulating the airway may exaggerate bronchial hyperresponsiveness and worsen the obstruction. If you consider the pathophysiology of asthma, this is something that you need to consider, especially. Yeah. So Your ventilator strategies, you need to have volume control mode. This is the most preferable over the pressure control. So, which is pressure control, which is limited by the high airway pressure. If you'd consider the fact that your airways are narrowed, yeah, so you're trying to get the same volume of air within, or a standard volume of air within a narrowed airway, the pressure is going to be higher. So the pressure is measured on the machine. So that pressure that's higher within the airways is back translated through the circuit all the way to the machine. Machine picks up and says, okay, the pressure is high at this point. So you have the machine cuts off your supply because the pressure has already attained the maximum. This is when you're using your pressure control mode. But when you're using your volume control mode, you need to consider the machine needs to still deliver that certain amount of volume. It can be aggressive, but you need to now this one now is what needs to be manipulated with the machine to try and deliver the volume in a certain way without causing other effects to the body. Now, so your respiratory rate needs to be low to moderate to allow for longer expiration time. So if you just jump to the fourth point over here, you need to have your inspiratory to expiratory ratio of about 1 to 3. So this is the time. So for every, say for example, if you're taking 1 second to inhale to have your inspiration, then you need 3 seconds to have your expiration, because like we said, the expiratory phase is a passive phase. So you need to allow the body to expel that volume of air that you have delivered, and it takes its time. It's not like inspiration where you can sort of force it down, yeah, with the machine. Sometimes you could even go to greater to promote a full exhalation, just to try and the whole point of this is to try and avoid the auto peak, so the positive pressure that keeps on building with every breath. And like Faith said, your tidal volumes of between 6 and 8 ml per kg are of ideal body weight. The just to mention it as a passing, for ideal body weight, you need mostly your height, yeah. You need it's a bit of a complex calculation that needs your height. So you need to add a 50 plus 2.3 kgs times your height in inches minus 60. It's a formula that I can share. It's on medical. Now, so still on your ventilator strategies, in obstructive airway diseases, your airway is narrowed. This airway right here is narrowed, yeah, and the flow for the flow of air that you're delivering to the alveolus needs to, you need to provide a certain amount of volume, right? So the higher, when you shove a lot more volume through that narrowed airway, you get higher resistance. You understand? So now, if you consider that your airway pressure is calculated as the flow times the resistance, this section right here, plus your volume over the compliance plus PEEP. So usually in your obstructive diseases, this part is not quite affected, yeah. But if you're not careful, as time goes, you're going to be increasing this PEEP. You're going to be increasing it as time goes by with every breath, and you're going to start getting airway trapping and more. So it's going to increase your airway pressure as well. So that being said, you still need to monitor your airway pressures. Your maximum pressure in your alveoli is what you need to mention. Is what needs to be about 30 per kg. 30 cm of water. Yeah. And the best way for you to do that is through what most ventilators have a section called an inspiratory hold. So what happens is that you're going to, at that point, you measure when the flow has stopped. So there's no air being delivered through the airway, and you pause it, and then it checks the pressure that's within. So what that does is it reduces this resistance, this flow to zero, the resistance is zero, so you sort of cancel out this section right here. And then your airway pressure then becomes your volume within the alveolus or the compliance plus the PEEP. So this is what still needs to be 30, because this is where the damage would happen if you proceed with higher pressures than normal. So that alveolar pressure then is what now we call that plateau pressure. Yeah. And that is the inspiratory pause pressure. And if you consider, there's a graph. This is what displays that very well. Now, your like I've said, once you hold the breath, instead of the pressure coming back down as you're getting your expiratory phase, you hold, and this pressure is what is measured. There's a little spike here because even as the air is coming up, there's still quite a bit of resistance, especially here in the airways. So there's still some pressure that's built up, and that's going to be translated backwards, and will give you an erroneously high level over here. But once you hold that area, that pressure stops, and you measure whatever is within your alveoli. Now, so you need to manage your PEEP generally, and you do that by helping to prevent alveolar collapse. So you aim for a PEEP of less than 10 years, but something above 4, just to allow you to maintain your alveoli open and recruitment, as Faith has mentioned. Now, too much PEEP can worsen air trapping, like we've said. So you need to apply minimal PEEP to balance between alveolar stability and avoid auto PEEP. And you need to measure the true PEEP with inspiratory hold where there is no flow. So that's what exactly we've talked about. Auto PEEP, like I had mentioned, this is the graph I was talking about. So if you can carefully consider this at number 2 and number 5 and number 7, as you're going up, I hope you can appreciate the fact that this volume that is remaining within the lung is getting higher. So this section here is what accounts for the PEEP. But as you consider, the pressure, the volume at the end is slowly rising with every breath, because we are trapping. We're trapping air within the alveolus. And if you consider this, let's look at the pressure time graph. You're able to see that the pressure is slowly building up. Yeah, and this is what you're going to call your intrinsic PEEP. And if you look at your flow graph, you're going to see this is exactly what is happening. So the flow coming down towards zero is your expiratory phase, and coming up towards zero is your inspiratory. So as you're trying to exhale, the flow does not get to zero before the next breath comes in. Yeah. And that's the problem. So in as much as you've put your patient on a ventilator, you need to still monitor these graphs and see what is happening, because with this little notch right here is what tells you you're not getting adequate expiration. So you're getting airway trapping. You're getting air trapping within the alveolus. So auto PEEP, like we said, is pressure generated when complete exhalation does not occur. Yeah. Signs your patient ventilator desynchrony or increases, you're getting increased work of breathing. So yeah, you desynchrony, agitation, sometimes depending also on the kind of sedation that you've given, but you measure with your RASS score. Your management, you increase, so you increase your expiratory time, like we had mentioned, your IE ratio, make the increase the IE ratio, so maybe 1 to 3, sometimes even to 4, but so that increases the expiratory time, and you're able to monitor, and then you're able to reduce your respiratory rate as you do that, because in as much as even if you put your you reduce your ratio, the even if your respiratory rate is still high, then you're not doing too much. Yeah, this is a bit of a heavy slide as well. So before we proceed, basically the biggest thing about obstructive airway diseases with mechanical ventilation, the biggest thing is that airway trapping. So, and this tends to improve as you manage the underlying condition, the asthma, the COPD, with the necessary medication. You'll be able to see gross improvements with this. You're able to see the you're not getting trapping as much. Your airway not getting such high pressures as much. You're improving. Yeah. So monitoring and troubleshooting. So even this is generally just for vents, but specifically in obstructive airway diseases, you need to check your airway pressures. Yeah? You check your vent, you check your circuit, you check your ETT, and the patient as well. So, like I said, the pressure is read at the vent. So that means that this whole entire circuit could have a problem. But the first and foremost thing, you need to first of all find out if the patient is okay. Just assess the patient, check if their chest is rising, if they're breathing actually. You need to assess the patient first and foremost, and then you check these other circuits. Some vents, when the pressure is high, stop the flow. But I think one in particular, it's called the Drager or Drager, however you pronounce it. It rather than stopping the flow at that high pressure, it just reduces the flow, which technically reduces the pressure or allows the volume to be given still, because you still need to oxygenate the patient. Yeah. So this is if you're using a pressure control mode with somebody who has obstructive diseases. It would be better to use a volume control mode, but there's some volume controls that still have pressure checks, and they can alarm you. Now, high volumes, you need to check for leaks. If you're getting high volumes, and you need to check for leaks, especially now in the pressure support mode. This is when you're weaning off, like Dr. Faith has said. Now, okay, so minute ventilation, you need to check with the BGAs, right? This is the tidal volume and the respiratory rate. It's a formula of product of the two. You need to check with your BGAs and then adjust accordingly. So if you're still getting high PCO2s and low pH, then you need to readjust the vent, adjust your respiratory rate, adjust your IE ratio, however you may need to do it, just for better ventilation. Yeah. Apnea, mostly in patients who are on support mode. So you need to check on patient deterioration. So I'm assuming if you're putting a patient now on support mode, it means that you're trying to wean the patient off the vent. But if you're getting apneic and the patient is deteriorating further, then usually you need to back up and get back to a different mode, the mode that they were on before. Some vents have a sort of backup mode to the pressure support. So in as much as you're weaning them off by just trying to let them trigger their breath, then you give a certain amount of pressure, then you still need to you still need to have a mode that it comes back to in case of an apneic patient. It's fantastic, the advancements in medicine. So if you're checking your intrinsic PEEP, you need to check the expiratory hold, like we had mentioned, and adjust your IE ratio. If you're getting hypotensive, you need to check your volume status first of all in the patient. You need to check the drugs you're giving them. You need to check if you're getting gas trapping, mostly because, like we had mentioned, the pulsus paradoxus. You need to check your tension pneumothorax possibility. It's possible, especially with ventilation. It's not so common, but it's possible. Patient vent desynchrony. So you need to check your vent mode. You need to check your IE ratio, your mode of triggering, your trigger sensitivity as well, and the sedation. So I put this here because most times you find if there's a patient vent desynchrony, somebody will jump right quick to get them to up their sedation, to have a RASS of maybe what -4 or -5. But you need to first of all find out exactly what's the problem, because if you're getting desynchrony, all of a sudden, maybe if you hadn't changed the vent modes, then your something has happened, something has changed. Maybe your patient is waking up, which is a good sign, or your patient is getting worse. Yeah. Desaturations, you need to check your vent settings, you need to check your oxygen supply, your FiO2, patient chest. Sometimes if it's too much, you disconnect the patient from the vent and you bug. And just by bugging the patient, you'll be able to tell exactly where the problem is. If you're bugging and it's easy and the patient's chest wall is rising, then your issue is probably with the circuit. If you're and your oxygen supply. But if you're bugging and it's difficult, so there's probably an obstruction with the endotracheal tube, or your asthma, your COPD, your airways are getting worse. Complications of mechanical ventilation. So these ones are simple: ventilator-induced lung injury, so barotrauma and volutrauma, like was mentioned by Dr. Faith. Hemodynamic instability due to increased intrathoracic pressure, ventilator-associated pneumonia, so that's in almost all patients are going to be intubated. Wean off. So when you're weaning off, you need to consider your readiness criteria. So stable oxygenation and not too high FiO2s. Minimal auto PEEP, so or even absent auto PEEP, so you're just getting your regular PEEP. And reduce airway resistance. So even the pressures that are being delivered, the volume is being delivered, the pressures are not too high. So your weaning approach, you do your gradual reduction in ventilator support. So as you're trying to step down to pressure support mode, and then close monitoring. So general improvements in patient clinical status and lab parameters. So you need to consider also those things that brought the patient in and made the patient and got them to where they are. Additionally, I think it just calls to mention, but it's probably going to be mentioned in more detail when we're discussing weaning of the patient. But it's not unacceptable. Or let me say it is acceptable to try and wean off your patient off the vent, and you kind of need to be a little aggressive with that.
Okay,
and there's, like some people say, there's no shame in actually having to reintubate patients. And in fact, in some patients, even as you wean off, some of them might need to be reintubated. If you're not getting any of those cases, then it means that you're probably staying on the vent too long. For most patients, more than they need to, because for some will of course improve, and others will take them off and they might need to be intubated, and that's still fine, as long as there's a qualified team on the ground. Those are my references. Yes. Thank you. Any questions? So there are a number of questions over here. Okay, that was answers if the respiratory parameters. Okay. Yes, Rebecca.
Sorry, it was by mistake.
Okay, so okay, so I will now share Dr. Wanjiro's presentation. Just give me a second. Are you able to see?
Yes, we can. Thank you. Good evening, everyone. My name is Dr. Anjiro. I'll be presenting mechanical ventilation in ARDS. Next slide. So, in the previous sessions, we defined ARDS as an acute respiratory distress syndrome that is characterized by an acute onset hypoxemia and bilateral pulmonary infiltrates. There is a criteria for ARDS. You'll check that in depth. So it occurs in the absence of left atrial hypertension, and it's commonly caused by pneumonia. There are those that are lung related and those that are non-related. So in general, it's caused by pneumonia, sepsis, trauma, aspiration, and it leads to impaired gaseous exchange and reduced lung compliance. Next slide. So our goal of management for mechanical ventilation in ARDS, they said that we want to reduce or reverse hypoxemia and we want to reduce the work of breathing. So that is in summary. So you remember when you're managing this patient, you want to maintain adequate oxygenation. You want to minimize ventilator-induced lung injury because they said that go back, yeah. When in my study, they said that ventilation is not, or the pressure ventilation is not physiologic. So if you like get adverse effects, you're supposed to minimize them because it's not physiologic. So you want to minimize ventilator-induced lung injury. You want to optimize lung mechanics and compliance. You want to ensure there is low tidal volume. You want to avoid high plateau pressures and to prevent barotrauma and to allow for permissive hypercapnia if necessary. Next slide. So what are the lung protective ventilation strategies? So what I'd want to tell you, as you're managing this patient, there are your goals that you want to meet. One, you know the indications for ventilation in ARDS. One is if the patient has a reduced SpO2 less than 80. So when you're ventilating this patient, your goal is to reach a saturation of 88 to 95, and also the patient has increased work of breathing. So because of said ARDS, you have hypoxemia, your goal is to have a partial pressure of oxygen between 55 to 80. So those are your goals. So to meet those goals, you have to make sure your tidal volume is a target of 6 mL per kg of the predicted body weight, and in some books they said use the ideal body weight, which has the formula has been discussed. You want to make sure your plateau pressures are less than 30 centimeters of mercury, and you have to tailor your PEEP according to your patient, the patient that is there. You have to prevent alveolar overdistension by the minute ventilations that have been discussed. That is how you're going to reduce your alveolar overdistension and causing atelectrauma. Then you have to monitor compliance and adjust accordingly to the patient. Next slide. So what are the tidal volume recommendations? You begin at a tidal volume of 6 mL per kg. Then you adjust based on the plateau. You avoid a high tidal volume of more than 8 mL per kg to reduce the risk of ventilator-induced lung injury. You want to lower your tidal volumes, which may be required in severe cases. And you do this by regular assessing your ABGs, and you want to monitor the respiratory rate to prevent auto PEEP. Next slide. So what is the role of positive end expiratory pressure? So PEEP prevents alveolar collapse and maintain oxygenation. So optimal PEEP improves the functional residual capacity. So you use the PEEP table to titrate to your based on the FiO2 and SpO2. Avoid excessive PEEP to prevent barotrauma. And you monitor your hemodynamics closely as the PEEP can affect your venous return. Next slide. So how do you titrate your FiO2? They said in the books that you have to make sure you start with a high FiO2 and a low tidal volume. So and then you go decreasing your FiO2 and increasing your tidal volume because you don't want oxygen toxicity. So your FiO2 is high initially, and then you go when you're going down as the saturations of the patients improve. So as your target, remember, is 88 to 95. So when you start with the high FiO2, you going down. So you combine with PEEP to enhance oxygenation. You monitor your ABGs to the partial pressure of oxygen to, we said, to 50, and then you avoid long exposure to FiO2 of more than 0.6. Next slide. So the plateau pressure has been discussed in the previous discussion. So you want to maintain it below 30 centimeters of water to minimize the injury that you have discussed. So high plateau pressures indicate over distension or low compliance. So you reduce your tidal volume or adjust PEEP if the plateau pressure is elevated. So you check, is it your PEEP, is it your tidal volume? And continuous monitoring is essential for safe ventilation. Next slide. So your driving pressure is, you get it by minusing the plateau pressure minus the PEEP. So a lower driving pressure will improve the outcome. So driving pressure is guided by your plateau pressure and your PEEP. So they have said that there is associated high mortality if your drive is high. So you have to make sure your drive is below 15 centimeters of mercury. Next slide. So there is permissive hypercapnia when you're using the ventilator. So they noted they said in the books that when you note that despite you continuing ventilating the patient and the SpO2s are not improving, you can increase the respiratory rate, but you're not supposed to increase beyond 35. So when you're increasing the respiratory rate, you're giving at a low volume, because at the same time you don't want to over distend. And also when you are increasing the respiratory rate, you want to increase the rate of oxygen, the gaseous exchange. That's why you are doing the permissive hypercapnia. So it allows mild hypercapnia to limit the tidal volumes, and you want to increase the gaseous exchange. So you avoid in patients with increased, these are the contraindications for permissive hypercapnia. In patients with increased intracranial pressure or severe acidosis, and it requires monitoring of pH and hemodynamics. You ensure you are guided by your partial pressure of CO2 and the partial pressure of oxygen. Next slide. So sometimes also you might be ventilating this patient, and you note when you're ventilating the our SpO2 is not rising. Our goal of ventilation in ARDS is to increase the SpO2 to reduce the work of breathing. So despite ventilating their patient and there is no improvement, there are strategies that are employed to improve ventilations. We have recruitment maneuvers that has been mentioned there. Others, we have prone positioning, high frequency ventilation, inhaled nitric oxide. So these are maneuvers like you're in your last resort, you're ventilating the patient and the patient is not improving. So those are the recruitment those recruitment maneuvers. And to explain them, one, we want to, there are two methods. There's one where you keep the patient on CPAP, and then there's another you put the patient in pressure control mode. So for CPAP, they said it doesn't necessarily improve the outcome, but you can employ it. Yeah, that's what they said. Yeah. So you can move to the next slide. The prone positioning, it has indications and it has contraindications. So the contraindications to prone positioning are those patients with severe life-threatening shock, raised ICP, spinal instability, open wounds, but it is considered if the patient has severe hypoxemia. And prone positioning, I've been told it works. So you can employ prone positioning. So it shifts, it's because of, they say that gravity affects ventilation. So you find mostly these lower lung fields, because they are bearing the weight of the upper lung fields, they are likely to be more consolidated, and you have reduced surface area in the lower lung fields, and there's atelectasis in the lower lung fields, and then in the higher lung fields they tend to be open. So that's why when you shift the patient to a prone position, you're increasing the surface area for ventilation. So you shifting the ventilation to a less injured lung region. So it improves oxygenation in moderate to severe ARDS. So I've seen it work, I've heard it works. So you can employ it. The books that say 12 to 16, that is, you say you can use it between 8 to 20 hours per session. Next slide. When you're doing, you can employ neuromuscular blockade in severe ARDS. This one will reduce ventricular desynchrony and oxygen consumption. Though it's employed for short-term use, less than 48 hours. It requires continuous monitoring, and it's only used when you're sure of your hemodynamic status, which is it's okay, it's normal. Next slide. There's extracorporeal membrane oxygenation. So this I read it said this is where I can explain. There's a machine that is outside, so blood is taken out of the body, and then it's oxygenated from outside, and then it's returned to the body. So this is where it's employed when you've tried to ventilate without improvement. So it pumps blood outside the body to a heart-lung machine, and then it removes CO2, and then it oxygenates the blood. So it's used when there is a cardiac and circulatory failure. So the benefits, it provides an opportunity for the lung to recover or transplantation. Yeah, next slide. So all in all, in summary, when you're managing this patient with ARDS, you're guided by your SpO2, you're guided by your ABGs, your partial pressure of oxygen, partial pressure of CO2. You have to do a chest X-ray to rule out consolidation. And they said in ARDS, your goal of management is, as in how you're going to resolve ARDS is managing the cause like the cause of ARDS and maintaining hemodynamic stability. That's how you're going to get out of ARDS. So yeah, so hemodynamic parameters, you have to monitor them so that you can get out of ARDS. And then what we said about maintain your FiO2, you have to start at a low rate at a high rate as you go down. Yes. Next slide. So weaning off from ventilation, you start when lung mechanics and oxygenation improve. Then you assess the readiness based on the daily spontaneous breathing trials of the patient. And then also you monitor your hemodynamic stability. Also, you monitor the signs of respiratory fatigue. Maybe when you're trying to wean off, you see the patient has increased work of breathing. So that means that patient, you can't wean off that patient at that time. So you'll be guided clinically, and it's subjective. So also you have to gradually reduce your PEEP and FiO2, which is essential. And then note, avoid premature extubation to prevent reintubation. Next slide. So what are the complications of mechanical ventilation? They have been mentioned: barotrauma, volutrauma, atelectrauma, oxygen toxicity with prolonged high FiO2, ventilator-assisted pneumonia, and hemodynamic compromise with high PEEP or intrathoracic pressures. Next slide. So what is the role of sedation and analgesia? It ensures the patient's comfort and ventilator synchrony. You have to use minimal sedation to avoid prolonged weaning, and it's individualized based on the depth of the ARDS. You combine with analgesia for pain management and monitor for adverse effects like hypotension or delirium. Next slide. So key guidelines: use lung protective strategies, avoid over-reliance on recruitment maneuvers or PEEP or high PEEP, early prone positioning for severe ARDS. Permissive hypercapnia is acceptable within pH limits, and always individualize your treatment based on the patient's response. Yes, that's all. Yeah, we're done. I'm seeing a question in the comment section. An ethical question is ECMO is quite expensive and majority of the outcomes are poor. Lung transplant is not available in Kenya. Will it be ethically right to send a patient to ECMO, especially if the PF ratio is less than 100? Well, in my opinion, I've not seen it being employed. I've just seen it in texts, in books. Well, I think this one, you have to give the option to the relatives, and then they will decide. They have the autonomy to decide if they would like us to employ it or not, and they have to consider the financial implications. So that one will depend on the relatives, because they're the ones who are going to decide on the patient is not fit enough to make that decision. That's my opinion. Yeah. Do paralytics reduce PEEP requirements in COPA? Dr. Kapanga says I would give the option, especially if I'm at wit's end. Yeah. You have to, you give all the options. They will decide. Yeah. Anyone else? Any other questions, suggestions?
Just to add, I think for it would be on a case by case decision, but the goals of care are what would be your biggest guidance, because the ethics of it would now depend chiefly on your goals of care. If the family, especially in a patient who's really deteriorated, don't want that, then I mean, there's no point. But if they want everything done, then might as well do it if the option is available.
Okay. I'm done. Thank you for your time. Over to Paula.
Yeah, Dr. Onjiro, Paula has asked if there are any special requirements for mechanical ventilation in the pediatric population. Are you able to answer, Dr. Onjiro?
Hello. I'm not so sure about the pediatric population.
Okay. Okay, we have other pediatricians or aspiring pediatricians on the call. I think one of them should pick it up. In fact, two very good doctors are on this call and active in the chat. I will not point names or name fingers, but they know themselves.
Okay, I think let me try. When you're asking about, I think when you're asking about special requirements, I don't know if you're asking about ARDS in specific, or in general in terms of mechanical ventilation. I'm not sure. Okay. Generally, I think the only difference would be, first we determine doses based on patient's weight. So for majority of the sedatives and paralytics that we use are dependent on patient weight. In terms of mechanical ventilation, what I've seen a lot is, or probably it's because of the kind of conditions that we manage in ICU, is that we use the pressure control mode for majority of the cases. I haven't seen actually a patient where we've used volume control in my short practice in ICU, which is probably like 2 months or so. Maybe Dr. Kapanga might have better insights based on what she's seen.
Dr. Kapanga, are you able to chime in, or is that enough? Okay, yeah. Yeah, so she largely agrees with what Caleb has said. Though I think in any active session, there's still some curiosity that could be raised. We could always do a bit more reading. And that's something that we can still go and check. Nonetheless, I think it was a very active discussion. Oh yeah, so she says her patient population has not been too different. Yeah. Paula, is that satisfactory? Yes, it is. So I think it has been a great discussion. We are still junior doctors, still learning, still trying to contribute to the medical field in this country. And the greatest thing would just to be to continue to expose ourselves to the information necessary, especially with mechanical ventilation. Mostly because it's vents are not something that you read one day and you sit on it. It's something that you need to read and go and implement and see it, try, ask a lot of questions. And the biggest people are intensivists and pulmonologists. Those are the ones who would really build knowledge and also doctor up to date. But nonetheless, it was a good. I think it's a good gateway to the vastness of the information within the mechanical ventilation field. And it would be best if there's any question or any new clarification, share some new knowledge or even new papers on the like to the group, share some knowledge around. I don't know whether it's my position to do this, but there's something called there are a few trials that have been done that have been published and have made great impacts, especially with vents and ventilation. There's one called the ARDS NET trial, which talks a lot about the ARDS vent settings and critical care patients with the ARDS. And then there's also the PROSEVA trial. This is particularly in patients who are prone. If you're interested, you could read on the same, and we can hold an active discussion in the group. Nonetheless, I think we've done a great job today. Any other contributions from anyone? Okay. Yes, Paula, I will share them in the group. In fact, I'll try and see if I can download the papers and share them. Yeah, maybe we can critically appraise them. Maybe, just maybe. So, I think that's the end of it. Fantastic session, guys. I think we can have a good night.